I'm specifically going to be talking about potential uses of psychedelics for treating depression and some kind of where we're at in terms of the evidence. Is this something promising? What are the potential drawbacks? Yeah, where are we at? But working? No, that's not working. Okay. Before we dive into the science, I basically wanted to start with something a bit more personal kind of reflection. So if you're comfortable, I'd invite you to close your eyes. If you don't want to close your eyes, then that's fine. Just sit, just find a kind of relaxed posture and just feel yourself sitting, supported by the ground. And there's some reason that's brought you to this talk. Maybe you know someone who has depression, you've experienced depression yourself, or maybe just who's going through a difficult time at the moment. So just feeling that person close to you, feeling the difficulty that person is experiencing. So just kind of feeling into that. And then also feeling your care for this person. Your wish for them to be better, to find a way to handle whatever difficulty, whether it's depression or some other difficulty. So just feeling your sense of care, sense of love for this person. Maybe just taking a deep breath in, a deep breath out, if that feels good to you. And just kind of feeling that sense of care for that person. Okay, and if you had your eyes closed, you can gently open them now. Yeah, so I just wanted to kind of start from that rather than diving straight into the science. Because, yeah, what would be interesting to know is how many people know someone who has been diagnosed with depression, or they've been diagnosed with depression themselves. If you feel comfortable to put your hand up. Yeah, so there's quite a lot of people in the room. Next slide. Does that work? Okay, so I won't go too much into detail about the diagnostic criteria, how depression is diagnosed. Obviously, it needs to be diagnosed by a qualified psychiatrist or psychotherapist, and involves low mood, fatigue, lack of motivation over a long period. So more than 2 weeks is the kind of conventional definition, and it affects a huge number of people, around 5% of the population, 280 million people worldwide. And this is a little bit difficult to see at this size on this slide, but basically you can see the prevalence here in females and males. Generally, the prevalence is higher in females for a number of reasons. Social reasons, females more likely to experience trauma, for example. There are social pressures on females as well. Another reason might be that for males, then there's a kind of greater stigma in many cultures around seeking help for mental health, essentially. I also include this to highlight that depression is not just something to do with brain chemistry or something to do at an individual level, it's also to do with social factors. So you can see kind of 2 lines on these graphs here. So these are graphs of the prevalence of depression per 100,000 people and the age of the person in years on the x-axis. And you can see that the red line is kind of higher than the blue line. So the red line was during COVID. So this was a big social event affecting people worldwide, and we saw a huge or significant increase in the level of depression. So it's not just a social thing, it's an individual thing. It's important to address at that level as well. And not just brain chemistry, but we're going to be talking about neuroscience today, because this is the neuroscience conference. So just briefly to introduce some of the changes happening in the brain during depression. So you have structural and functional changes. I'm just going to highlight a couple. I'm not going to go into detail. This is just to provide some background for understanding the results that I'll be presenting later on. So one is reduction in neuroplasticity. So in the brain, our neurons are connected to each other by synapses, these connections between neurons. And these synapses are happening at so-called dendritic spines, so these points of contact between the neurons, and in depressed people's brains, then we see fewer of these spines, less connectivity between neurons. And another kind of change we see in a person with depression in their brains is a difference in the default mode network. So there's a change in activity, the connectivity within this network and with other networks. And so it's thought that this default mode network is basically being linked to self-referential thinking, and it might be related to the kind of ruminative thinking that's happening in depression. So there's being stuck in kind of negative cycles of thought and viewing the world. So this is a kind of linking of psychological theories with neuroscientific theories. How is this kind of state of depression being perpetuated? And this could be one way among a variety of factors: genetic, biological, social, psychological. So in addition to obviously the great suffering of depression in itself, to experience depression, and for people close to people who are experiencing depression, there's a risk of suicide, risk of self-harm, and there's also a greater risk of other diseases such as cancer, obesity, type 2 diabetes, and other stress-related diseases. So, and currently, it's kind of the main treatment. If someone says, I'm taking an antidepressant, then they mean a selective serotonin reuptake inhibitor, SRI. This is the kind of standard treatment at the moment. And these are helpful. They're definitely helpful in some cases. They have a kind of limited efficacy. They also have slow onsets. They typically take maybe a couple of months, 3 months to kind of reach their maximal efficacy. And what's more concerning is that around a third of people who take SSRIs, they won't have any kind of therapeutic effect. So there's really big reasons to want new therapies working on the brain. We'll move into talking about psychedelics. So psychedelic, around the time psychedelics kind of got introduced to the West, then there was a kind of discussion around what terms shall we use to describe them, and this was the one kind of landed on. Psychedelic, so it means mind manifesting, so it's bringing to conscious awareness it's a lot of unconscious kind of material. I just want to give some reference to traditional uses. So there's evidence dating back to even 7,000 to 9,000 BC, with some suggestion that psychedelic substances were already being used in cultures around that time, so stretching back thousands of years, often used in a ceremonial ritual context as a method of healing or of visioning in some way for the benefit of the society, of the tribe. And in terms of the effects of psychedelics, then they have this kind of hallucinogenic effect. So this is both in terms of altering sensory perception, so there might be visual hallucinations, auditory hallucinations, but they're also kind of changing the experience of the self and the world in a very profound way. And this is, according to some people, and in my opinion, the kind of basis of their effect, of their beneficial effect for depression, is their ability to shift how one perceives oneself, how one perceives the world, how one perceives the relationship between oneself and the world in a very profound and potentially therapeutic, healing way. Yeah, so they've been linked to mystical experiences, to spiritual experiences, and this is the reason they're also termed entheogens. So generating God within is the kind of literal translation of that. So generating a kind of spiritual experience. So in terms of the modern Western rediscovery of psychedelics, I just want to reference Maria Sabina as well, a Mexican sabia, so a kind of wise woman, or curandera, a kind of medicine woman. She never referred to herself in that way. So she was using psilocybin mushrooms in Mexico for healing ceremonies. There's some very disturbing history around that, basically a lot of kind of appropriation of her ceremonies, basically stealing the mushrooms from her and bringing them to the West. I won't go into that history, but just acknowledge her as a kind of a representative of a long lineage of people using psychedelics for healing purposes. Around this time, around the 1950s, then was a re-emergence of interest and scientific study of psychedelics. And one of the key figures is Albert Hofmann, who synthesized LSD, lysergic acid diethylamide, in the 1950s. This was completely by accident. He was looking for a drug to help with cardiovascular respiratory conditions, and he actually accidentally got some onto his finger one day and had a very bizarre experience. And I guess the rest is history, as they say. So that was the kind of beginning of the modern age of scientific study of psychedelics. Okay, so Albert Hofmann was working for a kind of pharmaceutical company called Sandoz Laboratories, and they distributed LSD in the 1950s for research. It was used in many different kinds of research, especially psychotherapeutic research. And there were a large number of peer-reviewed papers at that time, which seemed to show promising effects of its therapeutic effects. Obviously, LSD and other psychedelics became linked to the hippie movement in the 1960s, and psychedelics were being used in a very unregulated and, in some cases, or many cases, even very unsafe way. There was no container, maybe not even any intention beyond hedonism, and this led to a backlash and the banning of psychedelics, not only in this kind of personal consumption way, but also for any kind of research, even within academia as well. So this is a graph looking at the number of scientific papers published across time. You can't see the x-axis very clearly, but the peak at the beginning is kind of in the 1950s, 60s, and then at the end of the graph you can see it beginning to rise again with the kind of modern research renaissance of psychedelics. And this plot specifically is looking at clinical trials into different kinds of psychedelics. This actually includes MDMA as well, which is not really a classical psychedelic. It works through a different kind of neurochemical mechanism. But you can see trials looking at psilocybin, so the active compound in magic mushrooms, in grey. That's what we're going to be talking about mainly today. And then far fewer trials looking at LSD, which is in blue on that graph. So basically you can see a big rise in the last, well, this was actually, this graph only goes up to 2021. It's, increasing even more over time. So as I said, we're going to be focusing on psilocybin. So this is the active psychoactive compound found in magic mushrooms. So it was isolated also by Albert Hofmann in the 1950s, and this is the chemical structure of psilocybin. And as you can see here, it has a very similar chemical structure to serotonin. So this means it gives it the ability to act on serotonin receptors, so these molecules that are on the surface of brain cells, on neurons, that can bind to serotonin. They also bind psilocybin, so this activates these receptors. And so just to say briefly about the serotonin system, it's a particular kind of system. Serotonin is sometimes known as a neurotransmitter, so a molecule that's sending signals between different neurons, but it's also known as a neuromodulator. And one reason it's known as a neuromodulator is that the way the serotonin system is set up in the brain is that there's a relatively small number in terms of the total number of neurons in the brain, which are able to produce and release serotonin. These are found in the brainstem, deep down in the brain, and they project to the rest of the brain. So it has this kind of overall modulating effect on the whole brain. And you might know serotonin as a kind of feel-good molecule, so it's definitely been linked to mood, but it's also linked to appetite, to sexual arousal, to sleep and wake cycles. So it has many different functions within the brain. So psilocybin is metabolized, so it's broken down into psilocin, and this is the actual active component which binds to the serotonin receptors in the brain. So specifically, psilocybin and other psychedelics such as LSD, they bind most strongly to a specific type of serotonin receptor known as a 5-HT2A receptor. So 5-HT, 5-hydroxytryptamine, that's another word for serotonin. So it's by binding to these receptors that psilocybin is able to activate the neurons which express these receptors, which have them on the surface. So one important thing about 5-HT2A receptors is that they're expressed really at the highest levels in the cortex, so this kind of upper layer of the brain, and at far, far lower levels in the subcortical layers. And what this means from a physiological point of view is that actually they're very safe. They don't really affect regions of the brain that are involved in basic functions like breathing, temperature regulation, and so on. So physiologically they're safe. Psychologically is another matter entirely. Okay, so moving on now to discuss what are the results that have been seen in terms of using psilocybin to treat depression. So this is some data from one of the early studies. So this was a study in cancer patients with a life-threatening diagnosis. So they were given either a low or high dose of psilocybin, and here are the results, which were really just absolutely startling results at the time. So on the y-axis you have the percentage of participants in the study who showed a kind of antidepressant, a relief of their depression effectively. So the blue bar is the patients who had received the low dose, and the red bars are the patients who had received the high dose. So the first measurement there is after 5 weeks. So with the low dose, there's kind of 30% remission of the depression. With the high dose, it's close to 100% after 5 weeks. And then even after 6 months, the high dose is still at 80%. So this is really, really just really unseen at this time. Completely different from SSRIs, where the person's taking them every day. They get probably some kind of mild relief. This is like one experience, one dose of psychedelics, and then even 6 months later, there's still a really massive effect. They also measured anxiety in this study, and they saw similar results for anxiety. So this obviously generated a massive amount of interest at the time to investigate further the potential of psilocybin for treating depression. So how might psilocybin be working? So we talked about neuroplasticity a bit in the beginning. The fact that neurons have dendritic spines, so these points of contact between different neurons, and the brain is basically able to adapt itself based on experience. And the idea is that psychedelics work by increasing neuroplasticity, working as psychoplastogens, so making the brain more plastic within a short window, the window of the immediate effect of the drug, and maybe potentially a bit afterwards as well. So as I said, the idea is in depression that these dendritic spines are reduced, and then by adding or taking a psychedelic, for example, then this could restore the normal level of connectivity and in fact enhance the level of plasticity. So this puts the person into a kind of highly plastic state. So given potentially the right kind of therapeutic container, then they can learn to see themselves in different ways, learn to work with these kind of stuck thought patterns which have been confining them within a painful way of relating to themselves, relating to the world, and so on. This is a bit more into the science. So these are some microscopy images of dendritic spines. You can see the new ones growing in green. This is some data from mice who were given psilocybin. And it's just showing the elevation of the density of spines, the number of spines, kind of on the neurons, in red for the psilocybin compared to control in black. Another way that psilocybin could help to relieve depression is looking at kind of whole brain level now, is in terms of how different brain regions are communicating with each other. So you can see some plots of connectivity between different regions. So if you imagine all the dots around the edge of the circle are the different brain regions, and then you can see the lines connecting them. So in the placebo condition compared to the psychedelic drug condition, then there's an increase in connectivity between brain regions. And specifically the connectivity, we talked about the default mode network, this network involved in depressive rumination, so this cycle of negative thoughts, keeping someone kind of trapped in a certain way of seeing themselves in the world. Then there's evidence that psychedelics reduce the connectivity within the default mode network. And so potentially this could be one aspect of what's going on in the brain that's underlying the therapeutic effect. This greater kind of connectivity might also explain, the broader effects that are happening with psychedelics, the kind of the mystical experiences and so on, the emerging of unconscious content and so on, this kind of manifesting of mind that the word psychedelic suggests, connecting together different brain regions, so they're talking together to each other in ways that they haven't done before. And just to give some scientific data to this is a recent study where they tried to measure the modularity, so looking at how are the separate parts of the brain that aren't communicating with each other, or are they integrated? So the more modular, the more kind of separate. So there's a shift here from the baseline in grey to the post-treatment after psilocybin. So there's a decrease in modularity, more kind of integration, more communication between brain regions. And on the right-hand plot, there's a kind of scatter plot with the trend line. Then basically it's correlating the change in this modularity, the change in integration with the change in a depression score. So relief of depression, basically the less modular the person's brain became during the psychedelic experience, then the more they have relief from depression 6 weeks later. Okay, so I've presented just some brief evidence on clinical evidence. We're going to go a little bit more into detail now. So this is a study bringing together some data on SSRIs and comparing it to psilocybin. So on that first graph, you can see the effect of a common SSRI, fluoxetine, over a series of weeks, over 8 weeks here, about 2 months. And so basically, you can see that it has some level of improvement over placebo for most of that time, but it's not a great deal. Whereas the psilocybin has this much more rapid and stronger effect. So that's the kind of good story of psychedelics, the heaven story. And then there are also some more hellish stories. So adverse effects of various kinds. So some of these are relatively transient and mild, like headache and nausea are kind of common effects that people might experience who've done clinical trials taking psilocybin. But this is some data from one of the most worrying trials, I guess, where they saw an increase in suicidal ideation, so having suicidal thoughts, and of self-injury, which appeared to be related to the dose of psilocybin the person had taken. So this is something obviously very, very serious indeed. Say on the broad sweep of clinical trials that have been run so far, this has definitely not been the standard. In fact, I would say this has only been really seen in just a handful of trials. So it's important to understand exactly why it happened in this case and whether these kind of risks can be mitigated. This is data from a recent meta-analysis. So a meta-analysis is where you bring together data from many clinical trials and try to synthesize, combine that data. Do what? Sorry, someone's been pressing it for me. So this is combining data from 7 clinical trials. This is data from over 400 adults with depression who were treated with psilocybin in clinical trials. This is published in the British Medical Journal, so a very reputable journal. And basically, the take-home message is that there's a very clear effect on depression. So this is a really robust finding that psilocybin does have scientifically measurable benefits for depression over a number of clinical studies. As I said, there are also adverse effects. Some of these are transient. So here we have some percentages: headache 67%, nausea 27%, migraine 10%. These are just some representative data from one clinical trial. But yeah, we also have to take into account the potential more serious adverse effects and to understand under what kind of conditions do they arise. Is this something that can be realistically handled and brought down to a safe level? So on that note, I read this article in The Guardian a while ago about a clinic in Berlin, which is specifically offering help for people who had very difficult psychedelic experiences. And I should say that I don't think the people who are going to these clinics are the people who've been to clinical trials who've been taking psychedelics within a regulated context. These are people who might have experienced them in another context. But yeah, it's worth highlighting that these are very powerful drugs. They do have very powerful psychological effects, and yeah, they should be treated. I think something like electricity. We know how to handle electricity now. We can use it safely, but you know, electricity also has a potential to electrocute, to cause great harm, to cause death as well. So we should be wise about how we're using this kind of potency of psychedelics. This is just to illustrate some examples of where psychedelics are being used in different countries. So yeah, I don't know if there's a difference between the Scottish Sun and the English one, but they seem to be a lot more liberal. Yeah, so this is an example from Scotland of using psychedelics to treat depression, and an example from Utah in the States. So yeah, it could be psychedelics could really potentially be coming to a clinic near you in the next 5 to 10 years. We'll see. Also wanted to highlight Australia, which legalized the use of. Can we go back to the? Legalized the use of psilocybin to treat severe depression and MDMA to treat PTSD, post-traumatic stress disorder. So that was in July of 2023. Yeah, many issues around psychedelic therapy still. One is just the huge cost. It requires a very long period of therapy, over 3 months or so. The previous one, if you can. Yeah, so there are still issues to be worked out of the safety, of the cost, and so on. Okay. Right. How are we doing time-wise? Do you have any?
You've got 10 seconds left.
10 seconds. Either way.
How long's the video?
It's 4 minutes. I can leave it either way. It doesn't really matter. I can recommend this video anyway. I think it was quite balanced in its presentation of. This is talking about the use of psychedelics, also scientific study of psychedelics in Australia to treat PTSD, to treat depression, trauma, and so on. You don't have to watch it now. So there's a variety of open questions still in psychedelic research. So are the antidepressant results reliable? I presented that meta-analysis data on that it looks quite convincing at the moment. But most importantly, are they safe, and how can we create an environment that they are safe? Is it possible to create an environment where they are safe? A lot of the trials that are happening, they have very selective criteria for who goes on the trial. Obviously, they're using psychedelics to treat treatment-resistant depression, for example. But yeah, what conditions are they applicable for? What kind of people are they applicable for? There are a range of mental health conditions which they could potentially be applicable for. We need to find out. Are mystical experiences necessary for the effects? There are actually some people who try to develop psychedelic drugs, so drugs that also activate this serotonin 5-HT2A receptor, but don't appear to have hallucinogenic effects. So some people argue that actually you can get therapeutic effects without even having to have the trip in itself. And then, finally the issue of the set and setting, so the mindset that someone comes into the therapeutic experience with, and the setting, what's created by the therapist and by the situation in which the experience is happening, because as I said, with psychedelics, and you're basically placing someone into a kind of vulnerable state in some ways, an open state, and a state in which their brain is very plastic, and that needs to be handled with great care. So that's something to look into. Okay, so here are some books to follow up if you want to read more about the science.